William Hunter was a physician on staff at the Charing Cross Hospital in London, England in 1910. The focus of his interest in medicine was in the area of anemia and the sepsis producing such such means what? Producing anemia. He characterized the surgeon as having antisepsis. He characterized the surgeon as having antisepsis, and Hunter felt that although areas of surgery were immersed in antisepsis, the practice of medicine was often lapse and that septic suppurations unfortunately occurred as complications of various medical diseases. Suppurations unfortunately occurred as complications of various medical conditions. He ranked sepsis in medicine as the most prevalent and the potent infective disease in the body. He ranked sepsis in medicine as the most prevalent and potent infective disease in the body, focusing on the movement of staphylococcal and streptococcal organisms throughout the body, compromising specific regions or organ systems. When applying these principles to oral medicine, the physician was immune to the potential disease processes occurring in the oral cavity. When applying these principles to oral medicine, the physician was immune to the potential disease processes occurring in the oral cavity, regarding it as a matter of teeth and dentistry with which he cannot deal. Hunter referred to these oral conditions as oral sepsis, a topic he had lectured 10 years prior to his indictment. He claimed that all members of the medical profession had the responsibility to address oral sepsis. The matter of oral sepsis is therefore of urgent importance in relation to the whole multifarious and widespread group of affections, medical, surgical, and dental, caused by the actual presence or toxic action of pyogenic organisms, say staphylococci and streptococci. Hunter focused both on Hunter focused both on teeth and on supporting structures as being the seeds of sepsis. Seeds of sepsis, especially in the poor patients who could not afford dental treatment. It is in poor patients that these septic conditions are most common. They have had no care of their mouths. Their fate is the relatively happier one of having their septic roots lying exposed in all their nakedness, surrounded with tartar, that means say calculus, overgrown it may be by foul septic fungating gums, This sepsis is relatively open and above board. It stares one in the face when it is looked for. Although displaying Although displaying respect for the mechanical skills of the dentist, he voiced his contempt for the lack of awareness of the seat of oral sepsis. As mentioned above, the hunter believed that the seat of oral sepsis is the teeth and the surrounding tissue, citing it as surgical malpractice. Although displaying respect for the mechanical skills of the dentist, he voiced his contempt for the lack of awareness of the seat of seat of oral sepsis, citing it as surgical malpractice. In his presentation, Hunter cited systematic disease processes. In his presentation, Hunter cited systematic disease processes that he attributed to oral sepsis, such as gastritis, anemia, ulcers, colitis, and nephritis. He claimed that this evil was so common and widespread that it is impossible to deal adequately with it. That it is impossible to deal adequately with it. Needless to say, the dental profession would soon respond to this vehement indictment and succumb to the dictates of the medical profession. In 1912, Ryan was the first to respond intelligently to William Hunter's vicious attack on American dentistry. In doing so, Ryan directed the blame for the lack of concern for oral sepsis to the physicians. In doing so, Ryan directed the blame for the lack of concern for oral sepsis to the physicians. It has been unfortunate that the insidious nature of this grave evil has been ignored by medical men for so many years. This apparent indifference of the physician to oral sepsis has unquestionably had an important bearing on the reckless indifference shown by so many dentists to the presence of septic foci in the alveolus. It has been unfortunate that the insidious nature of this grave evil, that is oral sepsis, has been ignored by medical men for so many years. This apparent indifference of the physician to oral sepsis has unquestionably had an important bearing on the reckless indifference shown by so many dentists to the presence of septic foci in the alveolus. Additionally, he cites the low fees and the complaints of the dentists that they cannot get paid for the time needed to remove pulps properly and to seal root canals aseptically as causes for indifference on the part of the dentist. Additionally, he cites the low fees and the complaints of the dentists that additionally he cites the low fees and the complaints of the dentists that they cannot get paid for the time needed to remove the pulps properly and to seal good canals aseptically, as causes for indifference on the part of dentist. In describing the presence of chronic apical periodontitis with a maxillary gland incisor, Hin labels it as a source of septic poisoning. Labels it as a source of septic poisoning, which many practicing dentists were treating with the approach of letting sleeping dogs lie. Which many practicing dentists were treating with the approach of letting sleeping dogs lie. In addition, he supports Hunter's accusation of the poor crown and bridge prosthesis. In addition, he supports Hunter's accusation of the poor crown and bridge prosthesis and chides the gentle and hides the dental profession to realize that Hunter's observations are true. In addition, he supports Hunter's accusation of the poor crown and bridge prosthesis and guides the dental profession to realize that Hunter's observations are true. If such be the facts, then let us acknowledge them honestly, and in attempting to drag ourselves from this quicksand of dishonor, let us not forget that instead of criticism, we owe Dr. Hunter a debt of gratitude. If such be the facts, then let us acknowledge them honestly, and in attempting to drag ourselves from this quicksand of dishonor, let us not to forget that instead of criticism, we owe Dr. Hunter a debt of gratitude. Re-in urged the dentists to forget the antique methods of preserving dead pulp tissue and become familiar with a scientific method of obtaining strictly aseptic conditions. Re-in urged the dentists to forget the antique methods of preserving dead pulpal tissue and become familiar with a scientific method of obtaining strictly aseptic conditions. In 1913, Logan responded to overwhelming concepts of oral sepsis. In 1913, Logan responded to overwhelming concepts of oral sepsis, addressing the treatment of chronic dentoalveolar abscesses without extraction to prevent the spread of sepsis. In 1913, Logan responded to overwhelming concepts of oral sepsis, addressing the treatment of chronic dentoalveolar abscesses without extraction to prevent the spread of sepsis. Hartzell in 1914 provided a discourse on oral bacteria, their role in secondary infection, and principles underlying their transmutation and their paths of entrance to the vital organs. At the Panama Pacific Dental Congress in 1915, Buckley echoed the words of Ulrich that every tip of a devitalized tooth where the root canal has been properly or improperly filled becomes a locus resistantiae minori. In doing so, Buckley admitted that the removal of focal infection is appropriate, but not to the extent of wholesale unwarranted extraction. Not to the extent of wholesale unwarranted extraction. The majority of teeth this involved may be therapeutically or surgically treated so that they will not be a menace to the health of the individual. During this time, Rosenau and Billings were rapidly clarifying and espousing the concept of focal infection and elective localization. They felt that bacteria had a predisposition to lodge in specific areas, producing a disease process removed from the original site of infection. Rosenau, working in an Rosenau, working in an area of immature bacteriology without thorough radiographic diagnosis and using extracted teeth dropped into the tubes of media, secured mixed cultures of organisms from which he isolated Streptococcus viridans. He was concerned about this strain as being the organism of systemic infection. He was concerned about this strain because it is the organism of systemic infection. However, in 1917, Meyer criticized the culturing of extracted teeth as a diagnostic tool and called attention to the possibility of culturing normal mouth organisms and called attention to the possibility of culturing normal mouth organisms that contaminated the tooth during extraction. Grossman pointed out that it was disconcerting but true that practically every investigation dealing with the pulpless tooth made prior to 1936 was invalid. Grossman pointed out that it was disconcerting but true that practically every investigation dealing with the pulpless tooth made prior to 1936 was invalid. You can see in the figure 2. In 1928, Holman reviewed the literature critically and commented on the theory of elective localization. The specificity of the bacteria has not been proved, and the theory of elective localization is so open to misinterpretation and so limited in its practical application that it cannot be considered as a help in a solution to the problem. A critical general bacterial adaptation to environment is conceded by everyone, but the factors on the side of the host are more variable and far more important. However, the theories of focal infection and elective localization, when coupled were to have a devastating effect on the dental profession, as not only pulpless teeth but also teeth with any possibility of chronic inflammation or infection along with the surrounding periodontium were considered as the primary source of systemic disease. In 1918, Peak, in a common sense approach to this problem, in 1918, Peak, in a common sense approach to this problem, stated that all focal infection is not of dental origin, and that even though the medical profession has indicted the dental profession, we, that is dentists, are alive to the prevalence and importance of oral focal infection, and that we can be relied on to intelligently and conscientiously handle our end of the work. Even with this low-key approach, Peak chose to land a salvo in the lap of the medical profession. The ruthless extraction of teeth, as demanded by some of the physicians, is a crime against the patient, and indictment against the physician and the surgeon, and a sad commentary on the cooperation and understanding existing between the medical and dental professions. Even Rosnow deplored the thoughtless extraction of teeth. However, he did feel it necessary in the presence of systemic disease. Even Rosnow deplored the thoughtless extraction of teeth. However, he did feel it necessary in the presence of systemic disease. In the presence of systemic disease, no one deplores more than I the ruthless extraction of teeth that has been practiced in some instances as a result of the work on focal infection. No one deplores more than I the ruthless extraction of teeth that has been practiced in some instances as a result of the work on focal infection. Vital teeth free from pyorrhea should never be extracted except as it becomes necessary for restorative work. Vital teeth free from pyorrhea should never be extracted except as it becomes necessary for restorative work. The extraction of pulpless teeth seems to me to be indicated regardless of the appearance of the radiograms in cases of serious systemic diseases for which no other focus can be done. However, Rosnow did not limit his directives to pulpless teeth, especially multi-rooted teeth with deep fillings or caps which manifest evidence of infection of the pulp with or without pulp stones, and even symptomless teeth which react positively positively to vitality test and that has deep, and that have deep feelings and that have deep feelings may be the source of systemic effects and may need to be removed. Even with his teeth, he felt devitalization and the filling of root canal should cease. Throughout the first half of the 20th century, teeth and the seat of potential focal infection they represent have been implicated in multiple disease processes throughout the body, such as eye disease, arthritis, tonsillitis, stomach ulcers, cholecystitis, myositis, diabetes, and many more nondescript, unexplained, vague systemic conditions. While, while there was an overwhelming tendency to radically eliminate the teeth in the hope of resolving these medical problems, some astute investigators attempt to some astute investigators attempted to dispel this irrational, irresponsible course of treatment. As a physician, Hatton was one of the most vocal and sensible. In all humbleness, and as a physician, may I say a word to the physicians of this audience. The mouth and teeth, because of their position, are easily examined. Yet, a determination of the nature and extent of oral infection is a highly technical problem. It is true that anyone can acquire much information from the study of dental röntgenograms, but to presume to arrive at a definite conclusion. The mouth and teeth, because of their position, are easily examined at the determination of the nature and the extent of oral infection is a highly technical problem. It is true that anyone can acquire much information from the study of dental röntgenograms, but to presume to arrive at a definite conclusion solely from their examination is a type of folly that no good physician would be guilty of in the study of any other part of the body. May I suggest that pulpless teeth are not dead teeth, that though the pulps are gone, they are still embedded in a highly vascular fibrous membrane, and the nutrition of hard parts of a tooth is still an open question, and that the question of nutrition of hard parts of a tooth is still an open question, and that treatment and filling of the pulp canal can be accomplished even after infection has occurred. An additional theory which emerged from the conflagrations of vocal infection was the hollow tube theory. In their classic paper in 1931, Rickert and Dixon demonstrated halos of irritation around the open ends of implanted platinum and steel hypodermic needles. For them, this finding gave rather convincing evidence that the circulatory elements diffusing out of the openings of these tubes were not well tolerated by the vital tissues, and this was analogous to what occurs in the pulpless teeth. Therefore, root canal systems required a tight seal to prevent the irritation and inflammation of the periradicular tissues. In addition, the material used to fill the root canal or apical foramen could not irritate the tissues. In addition, the material used to fill the root canal or apical foramen could not irritate the tissues, and caution was expressed as to the use of these materials in root surgery, and caution was expressed as to the use of these materials in root surgery, especially copper amalgam, especially copper amalgam. While the need to prevent localized tissue irritation is valid, the hollow tube theory, as promulgated by Rickett and Dixon, was effectively disproved by Goldman and Pearson, Tornek and Phillips in the 1960s. Focal infection is not dead, although its tenets have been severely dissembled over the years. Although its tenets have been severely dissembled over the years, there exist today professionals who will espouse one or more aspects of the focal infection theory when a diagnosis cannot be made or successful treatment achieved. The quality and success of both non-surgical and surgical endodontics in contemporary practice, the control of microbiologic populations, and the present-day etiology for endodontic therapy have all had a tremendous impact on lessening the intensity of focal infection concept and dispelling it as scientifically unsound.